So today's meeting is going to focus around building a pro-home culture, starting with CKD education for better patient outcomes. And we have two great presenters today from Rogosin Institute. We're going to be starting off with Kim Davis. She's the Director of Home Therapies and Operations. We've done a lot of great work with Kim. Um, Rogosin has a really innovative and outside of the box approach to home and all their actions that they do. We've had our on-site team go and visit them, and they were able to see it in action and truly impressed. So we're really honored and glad that they are here to share with us today. So I'll let you take it away, Kim.
Thanks so much. And I appreciate all of you for inviting me to the call. I like to also share what we're doing here to hopefully inspire you and to give you new ideas and to support you with your own program with home dialysis because there's plenty of patients to go around. What I'm going to start with is a best practice of our CKD education program, which started off as what we call PEAK. Rogosin's PEAK program is the prevention and education in advanced kidney disease that offers patients whose disease has progressed a team of experts ranging from kidney specialists, nutritionists, social worker, nurse educator, and psychologist. So we've also developed some new specialties within that group. Just stick to that slide with polycystic kidney disease and some other health conditions. Also, they do research in that within that facility as well. Okay, next slide. So the goals of PEAK, one is to really provide the patient with an individualized support and a plan, and to have developed individualized journey is how I best describe it. Education to learn how they can best take care of themselves now and in the future. Rogosin's team also empowers patients to make decisions leading to better outcomes and enhanced quality of life. Okay, no, you can go to the next slide. Thanks. Okay, so referrals to kidney transplant preemptively prior to the need of dialysis. That typically runs for us about 25% linking to our own transplant program with either a live donor, a donor chain, and getting them worked up and on the list as soon as possible. Some of our patients that are ending up going toward dialysis may even only need dialysis for a short period of time because they may already have had their workup for a transplant, but 25% don't even go on dialysis, at least during the process. Luckily for us, we were right across the hall in one facility with the home suite, so we're able to go over and talk to patients, bring them on tours of the home training program, have them talk to other patients while our home patients are training. We'll introduce them to people who might be looking at the machines and what home dialysis is all about. We assist patients in navigating the medical system. This could be external physicians in keeping different appointments that they may need to keep. We do have some patients that, in particularly like with transplant and PD, may, like for example, go see a bariatric physician in order to be put on PD and qualify for transplant. So the team ensures that each patient receives a personalized treatment plan, taking into consideration their concerns and their goals. Just stay on this slide for a minute. So what we do is after visits on a weekly basis, the whole team has a Zoom call basically to go through what was discussed with patients. The transplant coordinator is on that weekly meeting as well. And we have a spreadsheet that has all of the patients on it, even after they've received home dialysis education. I would say 30 to 40% of the patients, if not higher, and I don't want to over exaggerate because we're good at home dialysis, but we have a very good number of patients that choose home dialysis as their primary treatment option when they go through this program. Luckily, the patients are able to have enough time to do education, where in other areas where I'm experiencing issues with health equity and also underserved population, that there's a high number of crash start patients. So um, we do have we have two P clinics right now. That model is expanding within the next year, which will really provide a great service to Brooklyn and Westchester. Okay, next slide. Rogerson acknowledges that it is a challenge to live with kidney disease. Personally experiencing visits with the peak team, we can see a lot of different things that patients are going through. It's a very difficult process for some, and what we do is we help patients to stay active, live independently, and take control of their health. So removing them out of a illness mindset to a wellness mindset is really the position that we take with patients. Next slide. Can you go to the next slide for me? Thank you. So I want to explain how we're a little bit different. So we have some amazing people over at NYP. And what they were able to do is they built a model that actually uses a predictable risk score when you look at different comorbidities you have and your blood work, where it will sort out patients and give you a fairly accurate prediction of how long this patient is going, how long it's going to be until this person needs dialysis. So we have a little bit of an advantage. I think in some programs where you don't have this type of information, it's kind of a random guess. You know, we can actually see like when the GFR is dropping in comparison to other months, it kind of collates all the data together and it pretty much ranks them and says, okay, your patient is going to start in the next 3 months. So it helps guide the treatment plan with treatment options and preparing the patient for dialysis as well. I feel it gives a more accurate timeline to somebody who you might see who has like a GFR of 8. They feel fine, and you know, you may not see them again for another year because they were able to medically maintain themselves, you know, from treatment in that time. So I feel that this really zones in on providing the needed information at the right time for the patient. Next slide. So like I said before, 25%, if not more, of the patients are transplanted prior to the need of dialysis. So they've never had to go, they never have to, you know, they do have options and modalities picked out before this time frame. They do still come to see the home program, even if they're on a track to get the transplant, so that they're educated, because you never know if they'll need this option in the future. Definitely is increased. We have a lot of direct starts from the P clinic into home dialysis, where patients don't ever have to go to an in-center thrice weekly program. We can arrange for the catheter to be put in the morning, and in the afternoon, the patient's admitted into the home training area, in particularly for HHD. We do acute PD start as well, so we can do that. And also, there's been an increase in medical management to delay the start of dialysis. This particular model as well is every month of dialysis that is not, the patient is not on dialysis and can be medically managed, is also to the government a savings. So, and it's substantial. And some of it is patient choice as well. Next slide, please. So some of the challenges in being realistic with all of you, patients who aren't on dialysis in the, you know, in coming through the peak program, I see a lot of people missing or avoiding appointments. we had a discussion about this this morning, because they might not be feeling anything that substantially indicates that, I have a serious health problem and I need to continue going to this appointment. So we do have challenges to start dialysis when needed. If we can manage to keep the patient off dialysis for another month because they have plans or other things to do, we will, the physicians will look at it and see, medically, if it'll work. But we do have patients that they will just, they'll refuse to start dialysis, and holding off too long, like I said. And some of them do crash start. So, and then when we've seen them after they've been hospitalized, they said, I should have listened to the team, at that point. But I think that a lot of patients get very scared with with dialysis being an unknown, with it's anxiety. Is it going to hurt? Is it going to, is something going to happen to me? Am I going to live? Am I going to die? We see a lot of different things. Patients could be undecided in the treatment plan. So we've done a few minimal transitional starts when they weren't quite sure, so that we could work with them more instead of putting them in center. We try to have 100% of everyone having a plan before they come out of the peak program and need dialysis. And what I've seen personally, as well as patients having a lot of life challenges outside of their medical needs. Next slide, please. So the peak team has many members. It has physicians, NPs, RNs, social workers, home nurses, and dietitian. Patients have access but are faced with many personal challenges of an unwanted diagnosis. There could be a need for mental health support. Some people have food insecurity, or they also have living condition issues that need to be addressed. However, they all have access to care, which is the most important thing, in my mind at least. Next slide. So empowering, I feel that the PEAK program, what it does very well is it empowers patients to be part of the process. And also in certain communities, they've had family members on dialysis. Some things you may need to consider in the process is, I see many patients come into the Peak clinic, and one of the questions I ask them is, have you ever had a relative on dialysis? And as soon as they admit to it, they talk about how bad the experience was, and it causes a lot of fear for them. Luckily, it gives us the opportunity to talk about how home dialysis is not like in center, and that's probably the best option, for you. We don't know where their family members were, as far as, we sometimes I'll ask where they had dialysis, but most of the time, the stories I'm told, they were in an underserved area, frequently talk about lack of staffing in the facility, lack of communication, did not know the physician at all. So, so that's a big challenge, and it needs to be addressed. Patients, we want to keep them productive, and so they may have work issues. And I think that having a reasonable conversation to flex the training, or they need to take an FMLA, and really encouraging them that they will be able to work even despite the fact that they're on dialysis, and even encouraging them to go back to work, and particularly if they choose home dialysis. Lack of social support. So while we have programs that do solo dialysis, um, I see a lot of people who actually come into the situation that have no family whatsoever, or they may not be necessarily connected with family anymore. I think we have to look at the reality of how people are living these days, and some can be socially isolated. So they may not have 10 family members waiting in the wings to give them a kidney, and they might not have someone to help them with home dialysis. But, at that point, we provide them with all the support that we can. And another resource to have, and address the food insecurity that's we've learned a lot about the different programs in New York, the Green Market and other food assistance programs for patients. Obviously, language barriers can be a pretty significant issue when you're doing this. We've been afforded with a language line that we can use a lot of different languages. You can also Google Translate into a lot of different languages as well. So, you just have to have an organized plan in bridging the language barrier gap. Actually, our website, our wellness site, which I can point out at the end if you'd like me to show it, but it's wellness@rogosinstitute.org, was an extensive website that was put together by clinical team and also part of our wellness ambassador team, who you are going to hear from Aaron Battle in a little bit. Next slide. So we have been involving more and more of our patient advocates, we call them wellness ambassadors, into a lot of different fabric within all of our programs. I love their involvement in the home program. They actually do all of the educational days in all the facilities for home dialysis recruitment. Some of them are present patients on the therapies. Most are transplanted, so they can speak to all of the options at one time, but they, run that themselves. And having strong patient advocates who understand what patient advocacy is, how patient advocacy can work for people, and also bridging that with the team who may not have an awareness of what patient advocacy is, either on a local or a national level, is really important. So, as I said before, dialysis is an illness, and our job is to provide them with tools to decide what is right for them to achieve wellness, even if they choose to not treat. We do support patients who do not want dialysis. We do support patients that go into palliative care. We've done many palliative care cases, and the patients, were able to be afforded with the right to pass in their home. But that is obviously a treatment option that if a patient chooses, we have to inform them, but we will always support them. Next slide, please. So, it'd be helpful as well while we're on this call is to also hear what your successes are, what your needs are, and what can we do to help you with your program.
And you can either unmute yourself or use the chat feature as well.
Yeah, I'm actually going to put the website in the chat because if you don't have materials, it's already done for you.
So Kim, this is Vicki.
Yeah.
One of the questions we often hear or kind of pushback we hear about this, and I don't know how much you can share on that, is how does this get reimbursed? Like a lot of people really struggle with the CKD education and they can't afford it and who's going to pay for it. And I know there's reimbursement factors. Do you use those codes to bill out for this service, in terms of supporting kind of this early intervention and working with all these different disciplines? The CKD reimbursement, like education codes, things of that nature?
The physicians use the physician codes, and so does the social worker. I do not know if they're presently billing for dietitian services. Honestly, I don't handle the billing for the CKD program. So that's slightly different than, what our home program is. I think everybody needs something, even if, I encourage all patients to come and talk to me no matter where I meet them. How do patients learn about the home dialysis? Hold on a second. I saw a good question.
I can read it to you.
Oh, yeah. No, I got it. Yeah.
Oh, you got it?
Mhm.
Okay.
How do patients learn about home dialysis before coming to the in-center treatment? I feel like a lot of patients get comfortable with in-center hemodialysis, and okay, so the first part, the second part of your statement with patients getting comfortable in-center is true. After a few weeks, or even in other areas where where you haven't had a home program and you open one, patients are quite resistant. And with this, when patients cut, so I'll give you an example of a day of a patient in the clinic. So they may come to see the nephrologist, and at that time they say, "Oh, it's time to, pick a modality, pick your modality. You should," and they say, "Follow me," and walk across the hall, and they walk into the home dialysis suite. Luckily, we've expanded this facility into 8 training rooms, and on a consistent basis, on a daily basis, it's full. So on one side, you may have home hemodialysis training going on, and on the other side, you have peritoneal dialysis. So we may start in the room if the patient is a little anxious by using our website first to see how pliable they are to coming into the real life scenario. Some people are a little scared, and you have to ask them. So sometimes I'll start with the website, then maybe I'll show PD with the dummy tummy. Second, third is where let's go take a walk across the hall. And at times we tell the patients in training, we do give tours to our patients who are maybe needing dialysis, maybe having to choose something. And so the training patients are actually giving feedback to the patient who's just looking at their options. One of those things recently was we have a lot of high-tech machines, either NextAge, and we also use Tableau. So the patient was describing, the training patient told the patient, "Oh, it's so easy because they've got this Guide Me software in here, and it's easier for me to set up the machine." Great. You know what? If the patients start interacting, I really don't have to say very much to get them to choose what they want to do after they leave. And I think, one of the things with all of the series of best practices as well is home is the first option, not the second option. Unfortunately, some of the clinicians don't have the opportunity to get in front of the patient as fast as they'd like to, especially a home training nurse if they're very motivated. I tend to find people even when they're still in the hospital. So, if the sooner you can get to them, the better. Even if it's engaging them with a phone call that you've heard that they have arrived, and how are things going. I do speak to offering them a patient advocate in the beginning as well, which I think Erin's going to talk about too. But you like I said, as soon as you can get the person on the near the home program on the machine, uh, and I always tell patients, look, like you can come in and after 2 weeks if you want to try home hemo and you really don't think it's going to work for you, that's fine. Then you can transition in center, but at least you gave it a go, as well. So it depends on how it is presented to patients as well.
Any other questions for Kim?
Quiet bunch today, huh?
I know. We can move on to our next presenter, and then maybe they'll have questions for you both after hearing him as well.
Okay, wait, here we go. Tom says, yeah, lucky to receive our patients from the same hospital and they're well educated. However, receive patients from different hospitals that seem to be lacking education regarding their choices and still see home PD as a last resort. I completely agree with you. You may work for a hospital that has a structure and programs like I have, which it sounds like, and then other hospitals do not. One of the resources I found to kind of work with is acute dialysis programs, but it's unfortunate because if you're not part of that hospital system, you may not have the opportunity to interact with them, but the hospital teams do need a lot of education as well. I agree.
All right, it looks like Gina put in there. I do find a lot of patients overwhelmed with the amount of material they need to
Yeah.
keep in their home.
Yeah. So I see pictures on Facebook and social media all the time. I get a lot of really great ideas from people. We do allow for bi-monthly delivery. I understand that certain providers may not, and that, and that is a significant challenge with in the receipt of the amount you get. So, PD and HHD, approximately 30 boxes every other week. We will actually show them, and we've kept pictures of how our patients have organized their dialysis areas. If they are keeping everything in the box, that's a problem, because you lose functional space when you keep things in the boxes, whether it's cabinets, whether it's set of dresser drawers. I personally used to go to the Goodwill in the Bronx. They had one of the best Goodwills, and I used to pick up furniture and bins and all kinds of things. And but part of the process I did in doing the home visit was actually understanding how they need to organize their home. And I have a book of all the ideas that people put online, like, here's my dialysis room. And I show it to the patient because I want them to start thinking about what their room looks like. But if you get all those boxes and you're not really crafty on how to put them away, it will be a problem. Personally, I'd love to see weekly deliveries be able to happen to patients. So I'm trying to work through that. Did the website get shared? I don't see it in the chat. I'll put it in there again. You
It's
can part of the thing with the website as well, and I know Aaron's on, so he'll talk to it too. We've actually linked our patient advocates to part of the website as well, where it says, like, hey, if you want to talk to somebody, call this number, which is my Brooklyn office, and I have somebody who coordinates calls and visits from the wellness ambassadors too, so they can
Kim,
get a direct link to a wellness ambassador.
Kim,
Yes. Hi, Aaron.
I have a QR code in my presentation, so
Oh,
they could be able to,
fantastic.
yeah,
Okay,
click
well
on it
then
and
we'll
see it.
just move on to you then, my friend. All right. I guess if there's no other questions, then you can move on.
all right. So this is Aaron. Aaron Battle. We've been talking about him. He has a really unique and exciting role at Rogosin that I'm really excited that he's sharing with us today. So thank you, Aaron. And just let me know when you want me to move the slides and we'll go from there.
Okay. Thank you so much. Welcome, everyone. Again, my name is Aaron Battle. I am the Wellness Ambassador with the Rogosin Institute. I was on dialysis for 7 years, 8 years, and I started with peritoneal dialysis, went into in-center for a little bit, and now I've been transplanted now for 16 years. Um, Working with the organization has been wonderful for me. I have been actually a patient advocate for many years, and some of you may know me because I also worked for IPRO for a while. But a while ago, I was actually a patient services director. But anyway, let's the next slide, please. I meant to take those off. Sorry. We want to acknowledge the Llewellyn Family Foundation. Actually, Bruce Llewellyn was a patient at Rogosin, a home patient. He was born in Harlem. He's the son of Jamaican parents, and in 1985, he became the first Black owner of CEO and CEO of Coca-Cola franchises and the Philadelphia Coca-Cola Bottling Company. He was he was among the nation's most prominent and wealthiest Black executives. And he also, there's some many things you can read about him. He was a patient at Rogosin. He actually was a patient on home dialysis. And the wellness program is actually has been was actually a part of why the wellness program happened, is because of him and his foundation and the family actually giving funding and a grant for the wellness program. Next slide, please. So once again, we have the foundation supported by the Brooks Wellness Program is supported by the Bruce Wellness Foundation, and the goal is to help bring equity to treatment and prevention of kidney disease in the underserved communities of Central Brooklyn. Now, that's the major part of the program. We actually work with 2 facilities in Central Brooklyn, but we also are able to work with any of the facilities in New York, the Rogosin facilities in New York City. Next slide, please. I apologize. I thought I took that animation off. But anyway, so the wellness program, we're a bunch of peers. There are 5 of us at this point, 6, wellness ambassadors who have been part of the, not necessarily Rogosin facilities, but in New York State as part of kidney disease. And what we like to do is ask patients and share our personal experiences and knowledge to provide first-hand support and guidance for patients to have them get their wings back. We say that all the time, that it's very important to empower patients before they can be informed and decision makers, and educate them on topics including renal replacement therapies, food choices, and importance of following the care plans. Next, please. One of the reasons why we're looking specifically on the wellness program for Central Brooklyn is because of the health disparities with regard to kidney disease in those areas. And so there was a paper put out a while ago. We're talking about understanding key social determinants of health at a neighborhood level is essential to promoting equity and the achievement of better health outcomes. What we were talking about is that it provides a brief social demographic and community health data profile of our study neighborhoods, which is Brownsville and East New York. So we're at two of the facilities out in that area, mostly, and it highlights what is similar and different between them, and delves into the resiliency at the heart of both communities that should be the foundation for building communities' health going forward. What we're just talking about here is that, and this is what the wellness ambassadors were doing out there, we see that in these areas that there's a huge disparity within these communities with regard to dialysis care. And so what we are trying to do here is to make sure that we help these communities get over some of these and actually make sure that they're getting the best quality of care available. Next slide. Excuse me, next slide, please. So these are some of the disparities that we see in health disparities in these areas in Central Brooklyn. Brownsville, the life expectancy is about 6.1 years shorter than New York City overall. Leading cause of death in this area is per 100,000 of the population is heart disease, cancer, diabetes, and stroke. And if you look at some of the darker areas, this is where the health disparities are most, and what the life expectancy being about 75.1%, due to the health disparities within these areas. Next slide, please. And as I stated, the cause of the data shows that about 47% of dialysis patients die from cardiac arrest. And I'm sure a lot of you know this because you're in the nephrology field. I'm going to say, but it's interesting because most of it, people seem to think that it's because of their kidney failure. It's more often due to, and not being clinician, but it's more often due to the left ventricular hypertrophy, and I always have trouble saying that, hypertrophy, and it's a narrowing of the left ventricular area, and also because the issue here is, and I think we're talking about home treatments, the fact that in-center hemodialysis is too fast. It's fast and it pulls on the heart, and that actually has some issues that we have with regard to death in dialysis facilities. And so I'll come talk to that later, but this is why we are looking at and recommending home dialysis more often than and trying to get especially CKD patients who have not experienced dialysis yet, to start home. I actually started at home with peritoneal dialysis, and I know that was better for me. It allowed me to work. It allowed me to have a better quality of life. And so I highly recommend it, and we highly recommend it. But I think, as Kim stated, is that, there's always going to be in-center dialysis patients. We know that, and that there are going to be many people who are not going to be able to go home. So, but this is what we're looking at, having our clinicians actually talk more and actually recommend more patients go to home dialysis. The second leading cause of death, and that's partially because of being in-center dialysis, is congregate setting. The thing is that we know this because of COVID and what happened to many of our patients during COVID. Unfortunately, they had to go to treatment. And what ended up happening is that many of them suffered from COVID, and we lost a lot of dialysis patients. But if many of them were home, there may not have been as many. But again, that is one of the reasons why we're talking about home treatments and talking about, especially also transplant. And also one of the other reasons being hand and access hygiene. We are still, even when I was in the facility, and it's really something that we still talk about and we still really need to look at, is hand and especially access, because we found on one call recently that many patients aren't washing that access when they get to the facility. The clinicians need to understand and technicians, when that patient steps on that scale, the next thing they should do is wash their access. Because we were looking at points where some patients may get offended about that, but we have to explain to them that the reason for that is that you've already left your home, you've gone somewhere else. If your arm's exposed outside, there's still your arm gets dirty. So that's another thing we're working on and looking at, making sure that a hand and access hygiene is followed. Next slide, please. So once again, with the wellness ambassadors, the biggest thing, and my biggest thing, has always been education. It's very important to educate our patients these days. If we look at patients who don't understand actually what is happening to them in dialysis, why are they there? Why are they sitting in that chair for 3.5, 4 hours? It's very, very important that those things, and that we educate our patients with regard to that. Also, helping them navigate their kidney journeys. What are they doing? How do you help? As clinicians, I'm going to say that many of you are on here clinicians. I'm not sure what the audience here is right now, but I do want to say that it's important to talk to them. Important to let them understand exactly what is happening with them, not just in dialysis, also with when they're not in dialysis. What are they doing outside of? What other things are they learning? What other things do they do other than come to dialysis? And I think what's helpful when we're talking about home dialysis and also transplantation, that the journey changes. And education, again, is very, very important. And this also gives hope. It gives hope to the patients that we discuss this often, even within our within the wellness ambassadors, and even with patients, is that it's almost like the sword of Damocles is hanging over our heads every day, every single day. And we need to make sure that patients have hope. And there are a lot of things out there. There are a lot of organizations, etc., who are making the fact that kidney disease does not have to be a death sentence. That actually, with education, with help, with cooperation within the facilities, within the doctors, within the clinician community, that there's hope that if they go home, if they stay in center, or if they're transplanted, that there are ways that they can continue to have a better quality of life. It will not always be the way it was, but it will be better. And I think what's important is that patients understand that they can achieve a better quality of life. Next slide, please. I think this is going to be the slide where the QR code is. If you have your phones, you can actually click on this code and it should take you to our website. And am I able to share my screen here?
You can. Do you want me to give just another minute for them to use that QR code?
Sure, yes.
And then we'll stop sharing and let you share your screen.
Okay.
Thank you.
So I just want to go through the website a little bit. It was actually developed by the Wellness Ambassadors along with our Dr. Daniel Levine. During COVID, we actually did a lot of work on this website to help patients, to help the facilities and clinicians. And it's a broad spectrum of dialysis, diet, exercise, and I was just going to talk to you today. I'll show you today the pages of the dialysis modalities, et cetera, and what we've done with that. And we actually made it easier for people to read and understand. It's also can be, I can't remember how many you can translate it into many different languages. So it was our Dr. DeLevine, who works in technology, actually put this up there, and you can now actually many languages that most often are not included in some of these sites.
Okay, I'm going to stop sharing. Yep. Are you ready?
I think. Do I open? Okay.
And then you should see the share button. Yep. Oh, it looks like you got it.
Can you see that?
Yeah. Do you want to make it just a little bit bigger for us?
Sure. Is that better?
There we go. That's perfect. Thank you.
So once you go into the site, again, as I said, we have our buttons for hemodialysis. We're on this here. We talk about the beginning when we're talking about home dialysis specifically. It shows the patient what the machines look like. The one on this one right here actually is the next stage machine, and actually it's the one you can travel with. Patients can take this top part comes off, and actually you can take it on a plane, on a train, on a boat, wherever exactly it is that you're going in the car. The other one over to this side is the Tableau machine. That one is not portable, but it's a smaller machine, and it is used for home dialysis. Again, as I said, here are some of the benefits. It decreases the in-center COVID exposure and other infection risks, as I stated before. You see improved blood pressures and blood pressure control and fewer medications, and there are fewer diet restrictions as well. There is a voiceover here too that you can listen to, and also these pages are printable, that you can print this information and for patients so that they can see what's happening. So if they're interested, and also for social workers, technicians, all of you to give them information regarding home treatments. And there are some general questions as well. We haven't started self-care, but that's also something that's being looked at, and we find very interesting with regard to for patients to have happen within I'm going to say within the Rogosin system. We haven't started self-care, but we're looking at it to see to engage patients and talk to them about doing their own care within the facility. This would include cannulation and also learning the machines, etc. And also it could be a stepping stone for them to go home to home dialysis. That if they feel confident enough that they can do this, because you try to make sure that they can do this on their own in the facility with people watching them, that they can actually then do it home. So it's also a way for them to get home. The other thing here I wanted to show you is our transplant. And within the transplant page, we talk about transplant post, I'm sorry, just specifically in this one, there is a PDF here, a presentation that talks about some of the different things with regard to transplantation, donors, how you get a donor, deceased, living donor, et cetera, unrelated, those sorts of things, and it goes into many other different things. The other thing that we do have here, we talk about taking charge of your transplant, looking at the registry, the scientific registry of transplant recipients, to look at programs that they have, those kind of things that you actually would need to look at. There is another presentation here from the forum. Is a kidney transplant right for me, which can be downloaded and given to patients. The other thing here that we actually talk about a lot is that most patients and a lot of other facilities aren't aware of the donor chain and how it works, how we can talk to patients with regard to that. Two of our patients were part of two of our patients were part of a chain, and it actually lessened their time for waiting for transplant and getting involved in that. There's all the information that you would need for that, and how you can explain it to your patients, and how they can be part of the chain. There also is we also talk about, and it's not always talked about, that the fact that you can register in another state, whether you but you have to show how you're going to get there. You have to make sure you understand that possibly you're going to have to stay there for a period of time. But it is possible for patients in New York to register in other states. So, have the social workers talk to them about that, have them look into it. We have some information available. You can reach out to our wellness ambassadors, and we can actually provide some more information about that. Again, as I said, registering for a donor chain, also registering to donate a kidney as well. And also we have information about the transplant programs and dialysis facilities. I want to quickly actually show you too. I'm going to go back to dialysis, sorry. And this is another page that we actually, this was something that we really worked hard on, because as most of you know, patients are very concerned about what they can and cannot eat, and how does it affect them? Why do they not have, and why they're not able to have certain things? And we thought that this was very important for patients to be able to look at. There's some things on here which is, again, talking about your binders, etc. So, and again, all of this is patient driven. We all sat down together and talked about our experiences with regard to food, and how we dealt with it. We also have a section on mental health, which we find that another thing that we are now working on more often than not, but to talk about mental health with regard to dialysis and dialysis treatments. The reach out session, I think Kim spoke about that, is how you can reach out to us and wellness ambassadors. Here's a picture of our wellness ambassadors. And we also have how you submit information. And as Kim stated, it goes to the home facility where they contact us, contact the patient, and actually get us in touch, so that we can do a phone call, we can do a Zoom call, etc. So that has been a very, very good for us to be able to speak to patients. So just wanted to let you know that you had, and I hope you actually were able to use the QR code. Sorry, I'm stumbling today. I've actually been on 2 other calls earlier this morning, but so for you to be able to get the QR code, and that you will have an opportunity to actually look at this. I'm going to stop sharing, and to look at the website. So I'm done with my slides too. I think we're getting close. I just wanted to ask if there were questions and anything you would like to ask me with regard to the wellness program with me. I'm an open book. Thank you so much. And there you have that one as well.
That was great. Thank you. Does anyone have any questions for Aaron? Any questions about the website? Any questions about his role? So Aaron, I have a question. Do you typically meet with the patients, all new patients that start? How is, how do you meet with the patients? Is it when they first start treatment? Do you meet with them frequently?
It's not when they first start. We find that they're going through so much. If they know we're around. If they request us, we do. There is a group orientation that we participate in. The wellness ambassadors participate in the group orientation within these facilities, so that we will meet them there. We talk to them. They get more overall information with regarding education, regarding what they're going through, where they are within their process at this point. Again, when they reach out to us through the website, these are usually individual calls, and we have been having we go into facilities and have like a lessons learned or learn and teach and learn kind of uh, um, we have I'm calling it, I can't think my brain, sorry, lobby days where we actually are in the facility and patients can ask us questions with regard to anything. And we actually talk more, give information with regard to mistreatments with fluid overload, diet, any conversation that we can have or what patients are interested in. So that's one way we meet them. We're looking to do some other practices and projects in which we can get more either one-on-one and or group conversations with patients.
That's great. I see a lot of feedback in the chat. Thank you for this presentation. Very informative. I'm saving this website from Thomas. Thank you for this presentation. Another great presentation, and thank you. And another thank you for the presentation. I've learned a lot and will share with patients and fellow team members. So thank you very much. Does
Thank you.
anyone have any other questions for Aaron or Kim while they're both here? This has been great, though. Thank you guys both so much.
Thank you. I'm around. You can find me. If anyone has any questions for me specifically or any further information they would like to get from me, you can find me on the website and just do the reach out session and someone will get in touch with me. Or you can also I can give you I didn't put my email in there. I'm sorry. You can also email